Good evening. Hello, am I audible?
Yeah,
Yeah, good evening. I'm Dr. Mustafa. At the outset, let me thank Dr. Selvamani, who is my very old friend and colleague, for giving me this opportunity to moderate this session. In today's our session, we have 5 cases, and each cases will have 10 minutes. And what I was asked is like all the discussion and comments can be done at the end of the session. So one by one, each presenter will present their case, and we'll move on to the next case. And there is a slight change in the third case. I think Dr. Kuntal is not presenting today, and instead of that, Dr. Selvamani will be presenting a case. So I think we'll straight away go for the cases. Let me invite Dr. Rajesh Bandani to present this case on internal crush. Over to you, Dr. Rajesh.
yeah. Thank you, Dr. Mustafa. I think I'll just share my screen.
Yeah.
Okay, are the slides visible?
Yeah, it's visible.
Okay. So good
Yeah.
evening. I think the case that I'll be presenting probably is going to be a mini crush or a modified mini crush in the presence of an acute myocardial infarction. This was a 66-year-old lady, anterwall ST emulation MI, lysed with tenecteplase. Ejection fraction was 40%, diabetic, taken up for a CAG next day. And this was the angiogram view in the ariocaudal. Circumflex was very small. LAD as well as the left main was a pretty big vessel. And here you can see definitely there is a lesion in the mid LAD as well as the diagonal, which there is an ostial lesion, a very narrow angle, as well as diagonal we felt obviously was a little moderate or more than moderate size vessel, at least 2.5 millimeters, supplying a reasonable area which was there. So now we had to plan whether to really go for a single stent strategy or a two stent strategy. So LED was around 3.5 millimeters, diagonal 2.5, narrow angle. There was a discrepancy, significant discrepancy between main branch and the side branch diameter. So probably because we felt the diagonal was a reasonable size vessel, so we thought of a dedicated two stent strategy. And in that we felt, because it was an interval MI, mini crush would have been the best option, probably to avoid carinal displacement. Access to the main branch should be allowed, and obviously it would be a simplified with less steps in the ACS situation. So probably the first thing was done was wired both the vessels, LED as well as the D1, side branch dilatation with a 2 by 10 millimeter balloon done. And after that, obviously there was a haziness which probably thought of as a thrombus, came out because we knew that probably the stent would be easily crossed. Then we did the dilatation of the side branch or of the main branch. And probably here we had a little modification because it was a 6 French system. We took a balloon in the main branch. We kept the balloon and we took probably a stent 2.5 by 24 millimeter drug eluting stent. And obviously with a stent boost, we probably wanted to be sure that the diagonal strut or your diagonal ostium is very well covered. So almost we can see 2 millimeters of the stent before the bifurcation, and it's within the lumen which is there. And obviously we stent in the side branch was inflated first up to around 6 or 8 atmospheres. And after that, we probably inflated the balloon in the main vessel at almost 4 atmospheres, which is there. And after that, we obviously, next step was obviously we brought the diagonal stent little proximally, opened up the entire ostium very well. And then obviously we crushed it with the main branch balloon. The stent was taken out, and probably so that the carina shift doesn't occur, and the main branch access probably is made well. We planned to keep the wire because in that particular situation we could see that the diagonal flow was affected. There was hardly any flow across it, so we kept the wire over there. took the main branch stent, which was a 3.5 by 33 millimeter drug-eluting stent, deployed it. And after that, probably the first thing we did was we did a pot with a 4 by 8 millimeter balloon, so that the access into the side branch rewiring is much easier, as well as obviously the main branch stent is also well deployed. So the side branch was rewired with a fielder, and a post dilatation with a 2 by 10 balloon was done. This is the 210 balloon after the fielder, which was taken. And after the dilatation, we probably, that was the time, till that time there was no flow into the diagonal. Tirofiban intracoronary as well intracoronary nicorandil was given. And after dilatation, we probably brought a 3 millimeter, this was a 2.5 by 10 millimeter balloon, and that was a 3 by 15 millimeter balloon. Probably we tried to do a kiss over there, simultaneous inflation, which was done. And we brought both the balloons back, and we could see the flow into the diagonal as well as the LED was pretty good. Both the balloons were taken out, and a final pot with a 4-8 balloon, taking care that you do not disrupt the carina, was probably done. And this was the final shoot. The flow into the LED as well as the diagonal was well maintained. And this is the final result before and after the stenting. So probably the conclusion or the take home message, which probably is important, is planning of a bifurcation strategy in ACS is very, very important for long-term success. Keep it simple, primarily less steps, less hardware. Mini crush in this situation obviously keeps the carinal angle maintenance without compromising the main branch, and probably ensures that your ostium of your side branch is very well deployed. And obviously your side branch access also becomes better. And both the pots are very, very important. A proximal, the first pot after the stent deployment helps in the access of the wire, as well as the second pot ensures that you probably have really deployed your proximal stent in the main branch very well. Thank you very much for a patient hearing.
Okay, thank you, Dr. Rajesh. I think we'll move on to the next case by Dr. Girish Navasunti on inverted culotte. Yeah. Is Dr. Girish there? Hello? From the technical people, could you please find out whether Dr. Girish is there or not? Mr. Prateek? If Dr. Girish is not there, I think we'll move on to the next. Is Dr. Selvamani ready with your case for presentation?
Yes, Dr. Mustafa will present. By the time I think he will join.
Okay, no problem. Then I think you can.
Problem with him to probably has logged in, but some technical issue joining.
Or can we have a small change actually? Like we can discuss the case also immediately after the presentation, so that it'll be more easier.
Also fine. We'll do one thing. Probably you can discuss the first case. We'll give 2 minutes.
Yeah.
Otherwise, I'll start.
Correct. Yeah, sure. Dr. Rajesh, it was a very well done case, and the end result is excellent. One just small comment, probably like, having gone through the femoral route, probably I would have, and planned for a bifurcation, probably I would have selected a 7 French gate. So that it will make our life a little more comfortable. That's only difference, yeah. And if it would have been through radial, definitely, 6 is the one we use. Then another thing is, like, I think you have given the topic heading as an internal crush. So I was expecting the internal crush, but I think your case was not internal crush. It was a mini crush. Usual crush. So the internal crush, in which situation you do the internal crush? Can you just tell me?
Internal crush, primarily I would believe to do it in situations where basically, I'm already committed towards basically to probably stent the main branch, and then I want to really do the side branch later, and I probably then have to crush that particular stent which is there. That is a situation which is there.
Probably like, I mean, when we have plan for a provisional stenting and
Correct.
finally end up in losing the side branch,
Yeah.
and you're not able to do a tap, and if the angle is very narrow, probably
Correct.
that's the situation we can do an internal crush. But I think, the usual regular crush which you have done, that is the most preferred method.
Yeah, in this situation, the important part was that basically being a thrombotic milieu, I had already
Yeah.
lost the flow in the diagonal. So probably normally
Correct.
after the side branch thing, we normally remove the wire, deploy the stent, do a pot, and then re-enter the side branch. Here probably I allowed my wire to remain there so that my at least the access remains after the pot, which probably was very, very easy, and the procedure time was very less. And tap somehow I believe is predominantly an issue. Mini crush in today's era becomes the best option for getting your side branch ostium very well covered. Tap generally misses that, or unless you have probably IVUS or an OCT that you're going to use, that would be better off in that situation.
Okay, good. Any other comments from expert panels?
One point what I would like to say is doing a pot with a side branch wire may actually create problem. There are such instances where the wire was not able to be, get removed. So it is usually suggested to remove the wire before pot, unless you are very sure that the wire can be removed, and none of us can be very sure that wire can be removed, especially after doing a pot. If you are going for 1:1 high pressure dilatation for pot, it is actually safer to remove the wire, unless there's going to be absolutely no flow in that particular branch. In that particular situation, I would rather take a 2O balloon, open that ostium of the side branch first, and then remove the wire and then do a pot, rather than keeping the wire there and doing a pot. Because if wire
Yeah.
is stuck, it's everything is done.
So my issue was
Yes,
only the
yes.
same thing. The flow into the LED at the diagonal was almost 100%. So as you rightly said, there was an option of taking the wire in, but then I was a little worried that probably will that wire
Yeah,
go or no. So I
whatever
took
you have
that
done is the
chance.
best at that point of time. Yeah, in that
Yeah,
situation,
yeah.
you can even take a 0.08 or 1.1, 1.2, whatever it is, a balloon, nano balloon there, and then
Open
just
it up.
open the ostium. And then I have burnt my fingers. Wire didn't come out, so I
Correct,
have to
correct.
struggle a lot to get my wire later on, get the guideliner all the way down, but bang it across the proximal stent, crushed. I mean, kind of it was a mess.
Correct, correct.
So I mean that's I learned in
Yeah.
a hard way.
No, no, perfectly accepted. Absolutely right.
Yeah, it was a very valid point, and jailing the wire and doing, pot is not a good this thing. But at the same time, in your case, Dr. Rajesh must have worried, like, while doing pot, you may lose. Whatever access to the
Access.
side branch is
Side
there,
branch.
so in such situations, sometime what you can do is you can pull the main branch wire and try to enter into the side
The
branch
side
without
branch.
Exactly.
removing. Yeah, once that is done, then probably the side branch wire can be reintroduced into the main
Correct.
branch, and then we can do that. Is one thing which we can do, but it all depends, and in a given
Situation
situation,
based.
we choose. Yeah, we
Yeah.
choose whichever is more
Correct.
comfortable to us.
Most of the time we are lucky. Sometimes we are unlucky.
You're
Yeah,
right. You're right. Absolutely right.
I think it was a good case, Dr. Rajesh.
Excellent
I think
case.
we'll
Yeah.
move on to the next case. Is Dr. Girish ready? If not, please, Dr. Selvaman, you can proceed with your case.
No, I'm okay. Can I present?
Yeah, sure. Sorry. Yeah, I didn't know that you have come. Please.
Thank you. Thank you. Very kind. I just was following. This is not an inverted culotte. This was inadvertent culotte. I want to present a
Okay.
case where it was an unanticipated bifurcation that happened. This is one of my colleague was doing this case, a 62 years old male patient who had a chest pain for about 5 years, diabetic, hypertensive, interval hypokinesia, but still preserved viability, and EF was about 40%. And he had a severe single vessel disease. The proximal, almost osteoproximal LAD had about 100% occlusion. And in an outside center, they had tried to open that 100% occlusion. You can see this is how the case was. It was a pure single vessel disease. The right coronary was normal. And this is after their primary attempt. We thought we should open the LAD. We took a contralateral injection. It looked like a decent sized vessel, but there is an occlusion proximally. Since they had gone into a couple of false track, we had to use CTO hardwares to get into it. The We used a microcatheter. Initially tried with Pilot 200. It was always going to the diagonal. It wouldn't get into the LAD, and then changed over to Gaia 3, and then we could just cross down into the main vessel of LAD. Until this time, it was all good. To be honest, I just helped to cross over the wire, handed over the case, and then went for some other case, because henceforth it was very predictable outcome is what we thought, but I did not also anticipate, because it was a recent probable occlusion. And this has been a practice for us, that we always make sure that couple of struts prolapse or extend beyond the circ ostium. For whatever in the future, you can always do a pot in the left main, but completely cover the ostium of the LAD. That's been the principle at our center whenever you do an ostial lesion. And here you can see the struts have come couple of them beyond the origin of circumflex, and it was well dilated. It was 2.75 48 dilated with 3.5 proximally, and well opposed into the LAD. And this was again post dilated with 3 and 3.5, and this is how it looked post procedure. What can you see? It was a nightmarish. Patient started having chest pain. There was a hypotension. And if you look at the left main, it's all hazy.
Thrombus,
There is
yeah, a lot of thrombus there.
a lot of
Or
thrombus.
dissection. Yeah,
You know,
thrombus.
yeah, we didn't know. And then from the opposite lab, I just came in. There was hypotension. But what is strange is when they dilated, it looked very, very clean, very, very clean here. So whether post dilatation, uh, but eventually when we analyzed the whole procedure, we realized that large chunk of thrombus had migrated from the tuibu, that is the guiding, into the left main. It was not the de novo in the coronaries, but it went from the hardware into the coronaries. And we were stuck. Initially they were trying to do a thrombosuction, and they thought they should be able to get some thrombus out, but it was looking uglier, and patients started becoming unstable, because even the circ, you can see that is significantly thrombosed in the ostial space. What should be done at this point of time? I thought, LAD was anyway occluded vessel. Don't worry, he's going to withstand that occluded LAD. So we just went ahead and stented. But the most important thing here was, passing the wire through the LAD struts. We went into the LAD, came back through the struts. We crossed over to the circumflex, pre-dilated that the struts, and then took a 3.5 into 28 expedition stent into the circumflex from the left main. And you can see once we stented, patient started feeling better, hemodynamic stabilized, but the whole flow in the LAD got shut down. And this is what we did. Uh, Went ahead, recrossed the wire, just like a, it's, you could call it a tap or mini tap. So this is how we did, dilated the LAD. From left main to LAD, because anyway we were in the stent, and then we did simultaneous kissing. And this is how this looked end of the procedure. So the probably, at the ostium of the LAD, we had gone through some little subintimal space to enter, because there were multiple channels. And you can also see that diagonal flows are not great, because it was a lot of thrombus. But eventually the LAD and circumflex looked good. Thank you. The lessons for me here was, osteal LAD, whenever we do, I think it's worthwhile to have a wire. But more than anything else, when you want to when you want to position a stent in the ostium of either LAD or circumflex, always prolapse couple of stent. You never know what may happen, and optimize. Do a small pot opposing the left main, and subsequently, if you ever have to stent the distal left main, you could get away with one stent. You don't have to put another stent into the LAD. Thank you.
Yeah, Dr. Girish, it was a wonderful case, and more than the case, actually, I mean, the revival of the case was really great.
Yeah.
And I mean, of course, it's a nightmare, like at the end of stenting, seeing so much of thrombus in the left main. I don't know the real cause, actually. Your stent position was perfect, everything was perfect. I'm not able to come to a conclusion why this happened. Was the ACT was well maintained, and how much heparin was given? All the usual doses?
No, it was about 200 plus all the time. But when they
Okay.
checked back, this the guy who was operating was not opening the tuibu all the time.
Okay.
They were withdrawing the balloons, pushing the balloons without opening and letting the back flow. Otherwise,
Yes, another thing, what I can think of possibility is, like, see, this was like a CTO, and he must have been trying for long, and he was not injecting, and probably that blood, whatever which was come into the, into the catheter, was staying there. It was stagnant, and that developed clot, and probably at the end of one injection, things would have gone inside. So probably that may be the reason, I think.
quite possible.
Anyway, but you have yeah. Any other comments? Yeah, Dr. Ajit Menon.
Yeah, hi. Can I
please,
one
please,
comment?
Sure.
See, normally when you're talking about the two-way-burst related issues in withdrawing the catheter, withdrawing the balloon catheter, etc., or even with suction catheters, you tend to introduce air. Air embolism is far more common. Thrombus is usually, means that there is some issue with the ACT or with the heparin that was given, and the patient either was consuming too much of heparin, or the patient was resistant to heparin to a certain extent, and that is the reason why you had such an extensive thrombus in the inside the catheter, which could be pushed in. So otherwise, the catheter, even if you remain stagnant for almost 30 minutes inside the catheter with an adequate heparinization, the thrombus should ideally not form. Not for at least half an hour by the time the ACT remains beyond the range of 225, 230, 240. So I have a feeling probably the patient was in some way resistant to heparin or was consuming heparin, and therefore your whatever you gave fell inadequate as far as the heparinization was concerned. You did a wonderful rescue, because when the left main closes and the circumflex closes, it can be a nightmare, and you took the right decision in opening the circumflex, because that was a vessel which gave trouble, and your LAD also already was collateralized from the right. One question, sir, is that when you say you keep two struts of the stent in the left main, then why don't you come a bit into the left main only directly? Why keep two struts floating? Because then that may partially lie in the origin of the circumflex, and you are shifting the carina. You're getting a metal carina there. So why not get the stent into the left main and do a proper left main to LAD stenting, and then see how you can manage the circumflex?
No, fantastic question. I'll answer that in two phases. The first one, whether heparin is inadequate or response was inadequate, quite possible. But what made me think it was related to thrombus was, he said when I took a 3.5 balloon to post dilate, when I took it in, patient started experiencing hypertension and chest pain. So something went down. So I assumed it could be anything. Second, see, coverage of the ostium is very, very crucial. How would you say that I've optimally covered the ostium of a LAD or circumflex? You can only be certain when at least one or two struts come beyond the ostium, especially towards the origin of circumflex of the LAD. And I have felt it that it is always safer to have one or two struts. Tomorrow, when you do a crossover, you always have a drug eluting elution covering that place. Answering the second question, can we do crossover for all the circumflex healthy vessels? You can do that. We all can do that. But at many a times, I think we can get away just doing the ostium precisely. If you can position well, the angle is well visible. You can get away just doing it rather than getting more metal into the left main. We can then, the disproportion. It's about 4.5 in the LAD and 3 in 3 in LAD and 4.5 or more in the left main. So with the same stent, go into that size all the time. And then again, you'll have to cross over into the circ and open the struts across the ostium of the circ. And even that will not give you 100% opening. There'll only be some strut remaining. If you look at that, I think just leaving behind two struts is better than going across the left circumflex ostium and then opening the ostium of the circ. You will still have some struts not fully open.
Even personally, I too prefer to position it in the ostium, like what you have done, rather than coming into the left main, especially in this case where there was absolutely no disease for the LCX. I mean, I don't know, psychologically, there is some hesitancy in, jailing the such a big LCX.
One more thing, when you said that when they went in with a 3.5 millimeter balloon to post dilate, and that's when he started experiencing chest pain. One thing that we have noted, and especially with the thrombosuction catheters and with certain balloons also, you have a recent occlusion. You don't know the plaque morphology. Maybe a lipid-rich plaque, maybe a thrombotic plaque, maybe a red thrombus forming there. A lot of times what happens is,
Sorry, I'm not able to hear you.
There's something wrong with the audio. Yeah.
Can you hear me now?
Yeah, right. Yeah, please go.
So when you go in with a bulky catheter and you inflate you're inflating the inside the stent. If the plaque has a lot of thrombus in it, or is a lipid-rich plaque, if you deflate the balloon and you pull back immediately, you may pull back some of that material back into the left main. And that's what happens even with thrombosuction catheters. You're pulling back some of the material back into the left main, and somewhere on the line you release that material in the left main. So I don't know whether something like that happened in this situation. A thrombus which actually meant to be in the LAD came back into the left main.
About your point, Dr. Ajit Menon, we used to have a practice of pushing the balloon after the stent deployment little forward, that even if there is some debris, it might go distally rather than pulling into the left main. And another practice is like even flushing also with a little bit of dye or saline while pulling the. If there is too much of thrombus, that is another two practice which we usually do in our practice.
Yeah, very true.
Okay.
Looking at the volume of thrombus that you saw, I don't think it could have just come up because of the cage.
No. This is this is definitely in your case. Definitely, it is not something you pulled from the LAD. But another thing which I have noticed is in your case, see the catheter tip was not well aligned. See, sometimes we have this problem, like it was just hitting at the upper roof. So this is one place, when you take too many hardwares like balloons, and again it may rub the left main. And in my practice, I always make sure if the catheter was not well aligned, at the end I will do a good injection and make sure that I have not damaged the left main. Then only I come out. So maybe we don't know. Maybe there would have been some plaque rupture there and all that possible. Anyway, at the end it was a good result. I think
I would like to add one more point.
Please.
In such situations, actually, we can even slightly cock the guide and then get the guide all the way deep near the carina and then suck from the guide itself. So many times it helps. We will be able to remove at least 75% of the guide with the thrombus which is sitting in the left main.
Yeah, that is possible, but at the same, it is little risky also. We cannot take it as usual teaching, because deep throating the gate can have its own problem. If it is a real urgent and patient crashed and you don't even have a time to take a suction catheter, probably in such situation you can just do that. Or if you have time, probably suction catheter may be a better option, I think.
Yeah. Thank you.
I think if no more, I think we are running short of time, and please move on to the next case. I think I'll invite
Mustafa
Dr.
sir.
Selvamani.
Mustafa sir, since we are running out of time, we'll listen to Shafiq and Shivakumar, and after that, if there is time, I'll present. Please go ahead.
Sure. I think then I will invite next is Dr. Shivakumar. Dr. Shivakumar, over to you. Please go on with your case.
Right.
Sure.
Let me open my. That's what I'm doing.
Dr. Shivakumar is a senior consultant interventional cardiologist at Madurai, actually, MMHRC. Yeah, please, over to you, Dr. Shivakumar.
Are you able to see my slides? Are you able to?
Yeah. Very much. You are audible.
Yeah, fantastic. I was asked to present bailout sideband stenting. Luckily, I had a case in full screen. This was basically 55 years old male, diabetic, hypertensive, positive TMT. To begin with, normal LV function, visited an outside lab, a different operator. When the angio was done by the other operator in other hospital, it was planned for an LCX RCA PCI. After a satisfied PCI to RCA, when he was attempting stenting to the LCX VM, he noticed there was a dissection in the LM thrombus, and LCX was behaving nasty. So he quickly stented the LM to LAD, because all the time he was not able to get the stent out of the LM into the LCX. So in that bargain, he dissected the LM. Unfortunately, I couldn't share those pictures. He stented from the LM to LAD. Then I don't know exactly what he did for the LCX. He said when I interacted with him, he just wired through the strut, and he had abrupt vessel closure of the LCX. He wired, rescued the flow, and hemodynamic. He had a stomy course, hypotension, all that. Somehow he stabilized, and from the de novo artery itself, as he had a difficulty in stenting the LCX, having now stented the LM to LAD, he was really afraid to proceed further. And at this point of time, he referred the case to complete the stenting in the LCX. So when to stent the significant side branch after main vessel stenting? When there is a side branch stenosis more than 75, when there is a dubiosity about that, when you do an FFR, when it becomes positive, when there is a decline in TIMI flow, when there is a dissection in a side branch. Case like me, where either it started as a provisional, or in my case, it is like a real world case where when even there was no lesion in the LAD, but they had to rescue the vessel. So LM to LAD, they stented. Now it is like a provisional. Now the options are like T stenting. We all know that the default of T is, however you are precise, you will miss the ostia. The next option will be tap stenting. Again, the problem with this tap stenting is you have to be very good at how much you protrude. Otherwise, you will protrude much neometal carina, and this neometal carina on follow-up, how it is going to behave. Is there an issue of stent thrombosis? As well, when you have to re-intervene for some reasons of ISR, how these protruded struts are going to behave, all is a question. When it comes to culotte, particularly in an LM area, like particularly when the LM is long, leaving behind two layers of different overlap, however you call it as mini or micro, definitely at some point of some area, it is a two-layered. That's why decay crush is always most appreciated in, at least in LM. Let's move on to my case. This is how I got the case. This is LAO caudal. You can see there is a stenting from LM to LAD. You can really appreciate in epicaudal view. This was the lesion in OM, which made the operator to get the stenting, during which he dissected the LM and ended up in stenting the LM to LAD, and somehow he rescued. And this is in another view, RAO caudal. You can really see this LCX OM lesion is pretty long. The vessel reference vessel diameter is somewhere around 2.5. The lesion length is more than 25. This is the look of LAD. If you clearly see, the LM stent size is only actually to the size of LAD. Definitely, we all know that LM should be bigger than, even if you take it as LM of LAD of 3 and LCX of 2, 3 plus 2, 5, it should be more than somewhere around 4. But I think they put a 3 into 28 stent, but he admitted that he couldn't do all that post dilatation or optimization of the LM part of the stent, all that he admitted. So this is another look. You can appreciate the LM stent is not protruded up to the ostium of the LM. It is just falling short of the ostium, long lesion of the side branch, which is of interest now. The LM stent is just to the size of LED stent. Definitely, even angiographically, it looks like it needs optimization. So we started the case by OCT pullback from LED to LM, just to know whether the LED LM stent is adequately sized, adequately expanded, and how it got deployed in LM. If you look at an LED, at least in ostial LED, it looks underexpanded. In LM, it is not only underexpanded, it is inadequately opposed. So based on the EEL, all the measurements we got from the OCT, we took a 3 balloon for the LED and we expanded it further to make sure the LED part of the stent is further expanded, and we took a 3.75 balloon for the LM part of the protruded stent, and we know that it is underexpanded as well as malopposed, so we could achieve that. So basically, we optimized the earlier stent. Of course, the distal landing was good. There was no great disease down, no outflow disease, no edge dissections, no additional stents were required. Now, we crossed after the part, we crossed with the distal strut. Of course, I could have done an OCT pullback again from LED to LM, because just the previous day he had all these Tommy codes. The LV was down now from the abrupt partial closure. The patient is recovering. On the day of receiving the patient, there were disturbed hemodynamics, mild disturbance in creatinine, so that I have to be little calculative about my contrast use. So I didn't confirm that, but angiographically I was reasonably sure for this 2.5 sized of vessel with good optimization with the part of 3.75, which is even OCT guided. I was reasonably sure that it was a distal cross. Then now the initial operator had, even for the de novo vessel, I don't think he has tracked such a long stent. He had a difficulty. I don't know exactly the reasons, maybe inadequate dilatation or I don't know exactly. But we did a good part of the LM and we did a nice side branch opening with a 2.5 balloon. And now look at this, no great effort. 2.548 expectation just went in. And we could able to protrude. The initial plan was to just protrude, because when we did a part, the LM part of the stent was really splaying into the L6 ostium. So actually I was aiming for not this much of protrusion. I was little more, I wanted to be elegant about my protrusion. But what happens with expedition is the stent, the overhang is very acute. So the struts immediately starts when I was deploying. I think it was not to my satisfaction, because the splayed amount of the LM struts in the LCX ostium, I could have used it for a precise tapping without much protrusion to the LM. But even though I was aiming for it, it was protruded a little bit more than what I expected. Of course, we did post-dilatation, kissing, all that. I think we used 3.5 and 3. It's wrongly mentioned here. And now we did a pullback from LCX to LM, just to make sure that LCX then distally landed okay, no outflow, no edge issues, expansion is good. If you come closer to the carina, which is the point of interest here, you can see exactly at the carina, the LCX stent is well opposed, well expanded at the ostium. At that same point, the LED looking great. If you just move in some more into the LM, you can nicely see now the tap part of the LCX stent. One may call it as malopposed, but it is how it will look like in a tap stenting. When you do a OCT pullback from the tapped part of the vessel, you will see only like this. Probably if I had done an LED to LM pullback along the carinal side, I could have exactly known how it was. This is how the OCT run was done from LCX to LM, and this is the angio look of LED LM. Now you can appreciate really the LM part of the stent is really looking bigger than the LED. This information we got to the OCT. Because we optimized the LM stent, we could get the stent into the LCX, which initially caused a lot of problem for which the patient was referred here. And this is the caudal look of the LM, LAD, and LCX, looking great. And this is another view of epicaudal for the LCX. So this is the final result. Basically, I was asked to express more about unconventional techniques. To my case, having already stented LM to LAD, I have only options like T, TAP, and QLOT. I already said the pitfalls of all the three. The one unconventional which comes into my mind, if somebody feels that there was a discussion, protrusion, if it is more, what we can do. Either if the protrusion is more into the LM, or by intention, you can do a reverse crush or metal crush. The protruded part of the LCX stent, now LM, you can crush over the already deployed LM stent, then again you have to finish up with the kiss. But again, the problem with this technique will be the crushed metal, instead of over the vessel wall, it is crushed over the metal. So again, it has issues with the healing, uncovered struts. Because what happens in de novo artery, the hyperplasia because happens, the lipid accumulation happens, atherosclerosis happens over the low shear stress alongside the lateral walls. But it is not the case in a stented vessels. In stented vessels, when you leave uncovered struts over the carina with the crowd metal walls, then you get a near-intimal hyperplasia over the carina, then how you get restenosis. So one comes in my mind is metal crush. Other three I feel are conventional. I'm ready to learn. If somebody has any other unconventional ways of bailing out the side branch, I'm ready to learn from them. Thank you, one and all.
Thank you.
Thank you, Dr. Sivakumar. It was a nice case. And the left main to LAD was done from another center. Then after that only they referred the case.
Yes,
okay.
yes.
So did they have a plan to stent the LCX also? I mean, the OM also?
Actually, it was a two-vessel disease, no disease in LM and LAD. It was basically disease mid-LCX, that OM, mid-OM disease. They wanted to discrete stent over that. While tracking, they had a left main dissection. And
fine.
They quickly, because they thought they will lose the LAD also now.
No.
They quickly.
No, in that given situation, that was the best option, because you have to save the left main and LAD.
Yeah.
But otherwise, conventionally, I mean, if you have any lesion in the LCX or OM, first we'll try to finish that, then only we come to the LAD.
Absolutely, because this is too complex bifurcation. It's a long lesion. We could have started with the LCX, DK. We could have done a DK crush, LCX 10 protrude, crush it, and LM to LAD. So,
but in spite of having, I mean, left main to LAD, you really wanted to put such a long stent, or I mean, you were lucky that you could track such a long stent
because
through
the very lesion was in the OM in the mid. All the way, I have to reach there. And it's another extra 10 mm only. The target lesion was that OM lesion.
But it should have been very tough to track such a...
Yeah, it was tough, but probably as we understood the problem, as we discussed the case with the previous operator, as we could, OCT could help us, how the LM stent was looking, what are all the incompetence of those stent, we could able to correct it. And having understood the philosophy, now we were able to talk the stent. Probably we prepared
any other...
Now the question comes, if this LCX lesion would have been a calcific lesion, and if my pre-dilatation also would not be adequate and difficult, now going through the stent, taking rota will be. So now comes the support of guide liner, cross the strut, keep it wherever the closer to the area. That was my mind when the previous operator said, I don't know, the lesion was really not giving up. So even I was even thinking of, if the same story happens to me, how I will be taking the rota. So probably guide liner I should cross. Otherwise, I will be damaging the struts.
Yeah. Any comments from panelists? Any comments from panelists? Yeah, Dr. Girish, please. Yeah.
I just had one very elegant thinking by Dr. Shivakumar. See, we all can never exactly execute what we have in our mind at times. That happens at times.
Yes, Girish.
So in this situation, probably, this is one of the slightly thicker strut stent. So you need much higher pressures to firstly crush it. When we have many a times what I do, although it is said that do not do a crush with the wire inside, it never gets damaged. I have done so many crossover crushes with the wire in the side branch. You crush from the LMCA to LAD at a very high pressure, maybe 24, 26. Make sure all those protruding struts get back and crushed into the left main wall, and maybe they will occupy the circumflex ostium but not into the left main. So take a 4 mm stent or something from the LAD, LMCA across the ostium of the circumflex into the LAD and go at some 18 to 20 and then make sure they're all compressed into the circumflex. Then don't do another crush. Pull back the 4.5 millimeter balloon and go with a 3 mm or a 275 at a very high pressure, again at 28 or 30, and crush those stents which are across the circ back into the wall. And then you do a crush, simultaneous crush. Again, at that time, what I normally do, I don't know, is that I go at 24 at one side branch, deflate, go at the main to LAD at 24, and then come back and go at 5 simultaneous together. That to a large extent gets those whatever thickness of the struts, it tries to get them out of the carina and the ostial surfaces.
Perfect. Fantastic.
Yeah. Mustafa sir, we have left with only 10 minutes.
I think then we'll have only one more.
Yeah. Please.
Thank you, Dr. Shukman.
Thank you. Thank you so much. Thank you, Ananda.
Okay. I think, shall we go on to the next
jail balloon
please?
technique. Yeah, please.
Yeah.
Over to you, Dr. Shafiq.
Yeah, thank you very much. Good evening. I'm just sharing my screen here. I hope I'm visible and audible there.
Yeah. Please go.
Okay, so in the bifurcation coronary artery disease, one thing without controversy is that most of the time we use provisional stenting strategy with using single stent as a treatment of choice. So having said that, we just don't want to lose a branch. So a significant side branch, which is more than 2 millimeter in diameter, or which has a significant myocardial territory, we just don't want to lose. So we are conventionally, we used to do the jail to wire technique, but theoretically there is more chance of plaque shift, carina shift, and the change in the bifurcation angle, which lead to abrupt or acute closure of side branch during main branch stenting. In addition, spasm or dissection of the side branch also play a part, and it can cause perioperative myocardial ischemia. So sometimes because of all these, rewiring of side branch and restoring the side branch flow may find difficult, and prolonged impairment of flow can cause a peri-procedural MI. So this was first reported by a group from in 2010. So this novel technique that they proposed had to avoid acute side branch occlusion, which is called jail balloon protection. So theoretically, after preparation of both main branch and the side branch, the balloon, side branch balloon is positioned and the main branch stent is positioned. Side branch stent is balloon is positioned in level with, or maybe a little proximal to the proximal end of the main branch stent. And side branch balloon is inflated at a lower pressure, around 3 to 4 atmosphere, and then main branch stent is deployed. After that, the results are reassessed. This balloon is removed, and if needed, it is recrossed, and then the final port or preparation of the main branch is done. Theoretically, it is expected to have less of plaque shift when there is an inflated balloon while we deploy main branch. They did a benchmark testing as well, keeping one balloon and in the side branch and the stent here, and they kept it 3 atmosphere pressure. And during inflation, the proximal part of the side branch balloon is compressed and the contrast got squeezed, and typically this part in the side branch gets be overinflated. So after that, there has been some reports, but there is no major randomized trials comparing different methods. But recently there was a report of around 349 true bifurcation lesion treated by jail balloon technique, and they almost had around 5 to 6% of DLR reintervention rate. So the advantages that are proposed are plaque shift is reduced. The need of bailout stenting is reduced or abolished. There is better TIMI3 flow achieved. It can be practiced even for any level, any size of small branches. And it is less simple. It is simpler and uses less radiation.
ও ডক্টর তো ফোন করেনি, কোথায় ভর্তি কোথায় কিছুই যায় না তো কি কি
I think Dr. Hazra has to mute. Yeah, fine.
Yeah.
Please go ahead.
There are some limitation, but there is a major limitation of balloon get trapped if the proximal part of the main branch stent is longer, and it can theoretically distort the main vessel stent and cause some malposition which needs to be addressed. So let's see some cases. This one lady who had ACS, antral enstomy, with a LAD D1 bifurcation. So this was the angiogram where there was an LAD and ostial diagonal, which was of reasonable size. So we were planning a provisional stenting strategy. So dilated side branch, the main branch, and the main branch sequentially. The side branch balloon was kept. The main branch stent was positioned. The side branch balloon was inflated at 4 atmosphere, and main branch stent was deployed. And after that, the result was assessed, and the final port was the side branch was rewired before port, and then port was done, and it was post dilated, but there was no kissing balloon dilatation done, and we got away with reasonable result with TIMI3 flow in the reasonable good sized diagonal. This was another case. LAD diagonal diagonally here has some proximal plaque burden is high. So we did similar steps, and after the main branch deployment, recrossed. But here again, we got away without a kissing balloon. There was some plaque, persistent plaque there, but we did not go aggressively here because of the plaque burden, which might cause dissection and convert it to a two-stent strategy. So this was another case where the side branch was not much diseased, but it was having a good territory. And here the LAD stent was deployed. And after that, we did not even recross this lesion. And the last case here, again, the diagonal was of good size, ostium was diseased. We kept the balloon, dilated the balloon at 4, deployed the main stent, but again, it had ostial pinch, then we had to recross and do a kissing balloon dilatation, and finally we got a reasonably good result. So balloon embedded PCA is a novel technique in provisional stenting strategy, maybe a better alternative to jailed wire technique, and may be effective to prevent acute closure of side branch, especially if the lesion is complex. It is based on mostly individual experiences and small studies. It needs more randomized studies to compare with different strategies, either one stent or a two-stent strategy. Prevention of balloon entrapment is good, and we need to plan the length of the balloon and the quality of the balloon really good. And thank you. Thank you very much for the patient listening.
Thank you, Dr. Shafiq. You have beautifully described actually with your initial illustration and by real time cases. And I think it's an excellent, novel concept actually, having a balloon on the side branch, so that, as we all know, that in spite of wires, many times we lose the side branch. And one important situation is, like in all your cases, probably if the lesion proximal to the bifurcation is short, only we'll be able to use this technique. If the lesion proximal to the bifurcation is long, then I think it will be very difficult. And it can be, even you can have a lot of complications. You might even pull the stent also along with your balloon. And one question I have is, like, it is like a simultaneous kissing, no? You inflate both together, and which one you deflate first? Like you want to deflate the side branch balloon first and remove, and then only you deflate your stent balloon, or how is it? No,
we deflate both together and remove it. Okay. We don't keep we don't inflate that balloon immediately after that. Okay.
Okay, you first inflate the side branch balloon, that is the jailed balloon, and then you keep it in an inflated position and then deploy the stent.
Deploy the
and
stent.
then deploy the stent. Okay.
Yeah.
Then after that, deflate the side branch balloon and remove it, and then
deflate both.
Okay, both together.
Deflate both. Yeah. Then reassess.
Then reassess and do the pot.
Do the pot. Yeah.
Okay.
So the decision whether or not you have to cross again to the side branch and do a kissing is absolutely up to after. But always we address the main branch fully, and we make sure that the main branch is deployed fully. And after the pot, if we need to recross and do the kissing, do not hesitate. Just complete that process. And as you said, as you rightly said, if the proximal LAD is longer and calcific and having a lot of length of stent is planned before the origin of the diagonal, this is not a good idea.
I think Dr. Selvarmani is giving some hint. I think we are running short of time.
I think they are calling us to the main arena.
Okay, fine. Thank you for all the presenters and the panelists and all the participants. Thanks once again to Dr. Selvarmani. Over to you, Dr. Selvarmani.